With that, we're going to turn to our next speaker, who will be John Shu from the Harvard Medical School, presenting about the impact of the COVID-19 pandemic on patients with Alzheimer's disease and Alzheimer's disease-related dementias. With that, I will turn things over to you, John.
Thank you very much. It's a pleasure to be here. Thanks for organizing this, and it's a pleasure to see everyone in person, or at least virtually, I should say. I'm going to talk a little bit about our UO1. We're focused on the impact of the COVID-19 pandemic on patients with ADRD, and I'm really going to give you sort of almost a smorgasbord of appetizers, if you will. This being sort of year one, and all this stuff is unpublished at present. So hopefully we'll get this out in the literature soon. So, first highlight our team. We have a nice multidisciplinary team. We have some economists, statisticians, psychiatrists, neurologists, geriatricians, geriatric research experts. We have actually a physical therapy researcher, an ID doc, a neurologist, and a bunch of folks who have expertise in different areas. And while we have a pretty nice team, I think there's a lot of things, as others have said on earlier presentations, that where this is such a massive undertaking that the more skills and the more perspectives, the better. So first, quick outline. I'm going to very briefly go over the goals, talk about data sources, give you a couple examples of some early data, and then show you an example of some preliminary analyses, and then give you a summary. So we have three aims in this. Aim one is validation. Aim two is changes in outpatient care, and aim three is changes in inpatient care. And essentially, our perspective is that during the pandemic, health systems and hospitals were really highly stressed, as everyone knows. And this is in a context where we have a relatively highly regulated healthcare system. And there are, because of these threats, and particularly because of sort of some of the early events that occurred in different countries, for example, in Italy, where many systems were overwhelmed, there were some emergency policies that went into place that sort of relaxed the regulations for, among other things, outpatient care and inpatient care. All this occurs in a setting that's very dynamic, as we'll discuss. And one of the issues is the quality of the information that we get, and all of our information is observational. We're using these large data sets, is going to be of uncertain validity over time. And as we saw from the previous presentation, the number of visits and the types of visits and who was coming in and who's coming in next or first after the pandemic subsides was really starting to change. And another way of saying that is the information that we're getting from our normal data sources is also changing. So one of the things that we want to do is assess the validity of certain approaches that we've developed in the past. For example, how to classify individuals as having AD or ADRD, or other variables that are relevant, including things like race, ethnicity, or other measures, including even some outcome measures. One of the things that it becomes obvious is that, well, if overall outpatient visits are changing, as we saw from the previous presentation, or they're changing types of modality, that could be relatively important when we're examining what's going to happen. And then obviously the two aims 2 and 3 really focused on what those changes were and how they might impact individuals. We're using a lot of different data sources, and like others, we're using many linked data. And I think that's one of the, anyway, I'll stop there. We're using lots of different information, and I think this is really just a starting point. There's lots of more information we'd love to incorporate, and I think that's probably one of the most exciting things about this particular consortium. I'm going to show you a couple figures now, and here is a picture of daily deaths in Massachusetts. And what we did is we obtained regular feeds of death certificate information from the state. And what we did was model what the probability of death is, or what the mortality rate was in the state overall during different months, and that's the black line. And this is really is based on 2016 to 2019 data. And then what was the actual mortality rate, all-cause mortality rate during this time period. And we look at sort of the overall rate, as you can see, as well as those who have various diagnoses. One of the hopes is the quality of our all-cause mortality data is actually pretty good. However, we have a lot of concerns about some of the causes of death during this time period. And as many of you may remember, back in March of 2020, it was very hard to get a COVID test. And it was a really restricted group that had the COVID testing. If you fast forward about 18 to 24 months, the types of COVID tests that are available and who's getting tested and who's getting tested within the system versus at home is also similarly changing. If you look at places where people are dying, you get in a sense of another thing that's changing. A lot of it was really occurring in the inpatient setting or during home health. The other thing is it's a really relatively fluid thing, and the mortality rate is going up and down at different points in time, as we would expect given what we've all of us have experienced in terms of the local outbreaks. This is a look where we looked at where we calculated the excess mortality, which is how many more people died than expected given past behavior, past patterns at the area level. And then we created these quintiles of excess mortality, and we examined this by census tract. And we also superimposed that the locations of various clinics and hospitals. This is the state of Massachusetts. And as you can see, there's a fair amount of geographic variation. Similarly, there's also, if we were to look at this in terms of infection rates, there's also a fair amount of variation during this time period. So another way of saying that is, the actual risks associated with the infection itself or the spread of the SARS-CoV-2 virus really varied across areas. There's other things that will vary at different levels. For example, in Massachusetts, there were various changes that occurred at the state level or at the local level. This is a picture of some of the variation in the number of documented cases of COVID. And this is just a number of different cities within Massachusetts. And you can see some of the variation here. So another way of saying this is geography ends up being really very important. Here's a picture of outpatient visit rates and the modality of the visit during different months in 2020 within the Mass General Brigham healthcare system, and has roughly a few million individuals in the system. And one of the things you can observe is the overall size of the bars fluctuates. It really dropped during March, April, May of 2020, which is during the period where we had probably the worst components of the outbreak in the early part of the pandemic, as well as the most concerns by individuals about and uncertainty about what all this meant. Subsequently, there was some increase, but it fluctuated. The other thing you can observe here is the modality of the visit, the type of visit, whether it's a video visit or a phone visit, also fluctuated. And one of the things is we've noticed is that there's actually a fair amount of variation between whether it's a phone visit or video visit, and a lot of it will depend on any number of factors, including physician preference, as well as the ability of the patient to have high-speed internet access, as well as a sort of a private place within which to have these discussions. Here's some data that here's a look at some of the information that we're using from the state. And in this, one of their concerns is, as I mentioned, that the capacity or the nature of the hospital system was changing. And and one of the things that occurred was there was a lot of variation in terms of what occupancy looked like, as well as different strategies that healthcare systems applied in terms of how to handle some of the early episodes. And this is really a look where there were hospitals were able to report on a daily basis whether their occupancy was above their stated capacity, their number of licensed beds. And you can see there's a fair number at different points in time during the early outbreak, but also a fairly large number in January of 2021. And then here is a look at different hospitals within the MGB system and how they handled or rather their number of daily counts of patients with COVID. And as I mentioned, there was a lot of variation within the system. There wasn't any deliberate effort to concentrate patients within one hospital or another. A lot of this happened. A lot of this was driven by patient choices in terms of where to seek emergency care. Some of these places, some of the hospitals really altered the number of ICU beds substantially, in some cases up to 800% of their normal capacity, and others had much smaller changes. But we see a fair amount of variation. Another way of saying this is, the number of hospitalizations and the nature of those hospitalizations and the sources of our hospital data are also changing over time. So, so that gives you a sense of some of the issues that we're concerned about, both in terms of the sources of information, as well as different changes that are potentially promising to examine. Now I'm going to give you a quick look at some preliminary findings where we're examining the relationship between health insurance coverage and deaths. I'm just going to give you a very quick overview of this. First, it turns out that, as many of you might recall, we've had a fair number of individuals who have been uninsured in the past in the United States, with a number of different policies that passed as early as 2010. The rate of individuals who were uninsured has really been dropping over time. During the pandemic period, as per a number of surveys, it looks like that rate remained relatively flat. There weren't substantial shifts in terms of the uninsured rate during at least the first year or two. Subsequently, in the last 2 years, there's been a further decrease in the uninsured rate, and now it's now in the single digits. In the pre-pandemic period in 2019, which is, we believe, similar to 2020, at least with the best available data, we had a fair amount of variation even within states. Usually folks think about like Medicaid expansion versus non-expansion states. It turns out there's actually a fair amount of geographic variation within state. So what we did is we wanted to look at COVID deaths in the US, and this is using data from the CDC, and we looked at, this is a plot of the weekly number of COVID deaths in the US in the first 2 years of the pandemic. And, you can see that there was an initial spike in the March-April period, which we had discussed previously, but then subsequently there's a much larger spike in late 2020, early 2021, and then it goes up again in late 2021. When we look at places that have high uninsured rates versus places that have low uninsured rates, and we ask, how many COVID-related deaths are there in the CDC data, this is essentially what we see in the weekly mortality rate per 1 million residents. And in the blue line, these are folks that were living in areas with historically low uninsured rates. As you might recall, a lot of the early outbreaks were in the Northeast, particularly New York, Massachusetts, Connecticut, et cetera. And then over time, it gradually spreads to the rest of the country. And by the end of the year, it was affecting nearly all places. When we model what happened and examine, the relationship between the uninsured rate and COVID-related mortality, this is a picture of the differences we see as a function of the baseline uninsured rate. And we looked at the 10% rate versus the 20% rate. And we allowed vaccination rates, infection rates, unemployment rates, and social vulnerability measures to vary over time. And importantly, we used the time varying coefficient model with county level and state level fixed effects. And the reason is that because we were really worried that the nature of this was time varying. As you might recall, in early 2020, there was really very limited understanding of the virus itself as well as the disease. And there were really no treatments that we knew that were evidence-based. And then gradually over the summer, there was some big studies that came out that suggest that certain treatments were potentially efficacious. And then later, within the end of the year, we had vaccination. So the nature of the risk is also time changing.
John, just a quick heads up. We are just about at time, but it looks like you are wrapping up. So sorry, I jumped the gun. So
okay, no problem. I'll finish for now. So I think the main points are there are a lot of these data and classification issues. We're focused on the ADRD classification and how it might change over time, but this also applies to a number of other variables of interest. The nature of the delivery options, we've talked about the outpatient, inpatient things, but there's also some downstream things. For example, the availability of post-acute beds, SNF beds, which are often in nursing homes, really impacted hospitals substantially. So looking at sort of part of the balloon, if you will, it may not be sufficient. And as I mentioned, these issues of time-changing relationships is something that's concerning. So, the proverbial metaphor of the lamp, which we use to look for what's happening, it's a challenge when we're in an era where the lamp may be flickering. So with that, I'll stop.